Hi, Dr. Brian Hoffman. I'm the Chief Medical Officer, Executive Vice President of the CLL Society here at ASH 2023 in San Diego.
And I'm Alexey Danilov, Professor in the Department of Hematology at City of Hope National Medical Center in Los Angeles, California.
Dr. Danilov, we've found over the last decade now that blocking Bruton tyrosine kinase, or BTK, has revolutionized how we manage CLL and made CLL patients much better. But patients develop resistance eventually to most of these BTK inhibitors. You've been working on a new way to inhibit the BTK pathway with a degrader, NX-2127. Can you tell us a little about that research and what you're presenting here at ASH?
Yes, absolutely. So, Dr. Kaufman, you're absolutely right. Resistance to BTK inhibitors such as ibrutinib, acalabrutinib, and zanubrutinib, which we now use every day in management of chronic lymphocytic leukemia, is becoming an unmet medical need, where patients who progress, while patients enjoy a long-term efficacy of these drugs, which can work for often 5, 7, 10, 15 years, depending on the genetic subtype of CLL. Eventually, resistance is expected to develop in, I would say, majority of patients, sooner or later. And typically, this resistance is driven by mutations in the kinase, in BTK itself, where the drugs that we use, the small molecules that we use, which target BTK, no longer fit it perfectly, and therefore cannot reliably block the function of the kinase. So the new way of solving this problem is use something that you mentioned, you called BTK degraders. So what does the degrader do? Instead of simply blocking the kinase and disrupting its function, it actually binds the kinase and shuttles it through the cell degradation, protein degradation system, through the so-called proteasome. So every cell has a mechanism to get rid of unwanted proteins, of unwanted debris, of sort of garbage, right?
Right.
So basically,
get rid of the garbage. Yeah.
Exactly. So proteasomes are these little garbage trucks, and instead of coming just on Monday, they're always there. Things go down the chute and get expelled as small molecules in the end of the day, small parts of molecules. So BTK degraders grab the kinase, shuttle it to this chute, and therefore the kinase now disappears from the cell. And because the kinase is no longer there, obviously its function is now inhibited. But BTK degraders so far don't care so much for whether the kinase is mutated at one of the sites, which we typically see with BTK inhibitors, or not. So BTK degraders work across many resistant kinases. And this is how basically it works, because CLL cell is so dependent on this mechanism, on BTK, that even when it's mutated, it becomes even more dependent on it, in fact, because it begins to signal all the time, and degraders disrupt it in this novel particular way.
And my understanding is the degraders also seem to work with the, last week we got the great news that pirtobrutinib is now approved, and it binds in a different way, but these degraders also would work to patients who eventually become resistant to pirto. Is that what the hope is?
Absolutely. So in the majority of cases, and we learned more about resistance to pirtobrutinib at this ASH as well, so there are some additional mechanisms, but in the majority of cases, resistance to pirtobrutinib is still driven by mutations in BTK. And those mutations are different than ones which are responsible for resistance to ibrutinib, for example, but nevertheless, they are mutations. And in our study, we did have several patients who have been exposed to pirtobrutinib and have responded to treatment with NX-2127 with the BTK degrader. So indeed, it still is a valid therapeutic approach for these patients.
So tell us a little about this drug and how successful it's been, and also what are the adverse profiles, I mean, that you see with this?
Yeah, absolutely. So To make it simple, the study is still fairly early. We have enrolled 47 patients in total on this phase 1 study, of which 29 had chronic lymphocytic leukemia or SLL. And the majority of patients who went on the study actually derived clinical benefit. The official response rate right now is about 40%, but as you know, responses to BTK inhibitors occur fairly slowly, and as patients, as the follow-up on study increases, becomes longer, more patients qualify for response, right? So for example, the response rate now is higher than what we reported at last ASH, okay? So it is very promising, and right now the majority of patients have either partial response or stable disease, meaning that their lymph nodes are getting smaller, but do not quite qualify for stringent, strict response criteria yet.
Which is where they've shrunk by half.
Exactly, yeah, and also you need good recovery of anemia, thrombocytopenia, all this other problems.
Low platelet counts, low red blood cell counts. Yeah.
Correct, yes. So in terms of safety, this safety is actually very good as well. The drug is well tolerated. I certainly have patients who have been receiving this agent for over a year and are doing well. We do see some typical BTK inhibitor associated adverse events such as mild bruising, hypertension, mild neutropenia, but
low
neutrophil count. But the majority of these adverse events are well managed and do not result in discontinuation of the drug.
What about the cardiac events that we see, atrial fibrillation and even sudden death we've seen with some of the BTK inhibitors? Have you gotten any signal on that?
So yes, so we do see atrial fibrillation. Again, interestingly, the rate of atrial fibrillation in our study is actually going down. And I think that simply has to do with the fact that we're now more comfortable offering this particular agent to more patients because we know it works. So atrial fibrillation, however, has been seen. The majority of cases of atrial fibrillation have occurred in patients who either have experienced atrial fibrillation previously on BTK inhibitors or had some other cardiac issues, including hypertension, recent myocardial infarction, heart attack, or some other heart problems. Or in patients who are older, over 80, we actually have many patients who are of advanced age. Luckily, we didn't have any cardiac events or heart events leading to sudden death. We didn't have that. So, and I hope that won't happen because certainly that has been reported with ibrutinib. But other adverse events, like I said, are ibrutinib-like, so to speak.
Major hemorrhages, infections, have you seen that?
So we have seen a hemorrhage in patients with non-Hodgkin lymphoma, not CLL, who had extensive involvement of gastrointestinal tract.
Okay.
So, so that did occur, but unexplained hemorrhages, we haven't quite experienced that.
In infections, there's some increased risk of infections with CLL to begin with and with the BTK inhibitors?
It is hard to say. There haven't been infections leading, like there were no, for example, cases of sepsis leading to bad outcomes in our study. Yes, patients do get infections, but the reality is many patients are on this drug for over a year, right? So life just happens. So it is right now hard to say how much of this is CLL. Our patients have received between 4 and 5 prior therapies on this study. Some received 10. Most had chemotherapy, so they already come in with fairly low immune system. So right now it's difficult to know whether infections that we occasionally see are related to CLL, prior chemotherapy, or the drug effect. But none of them were fatal.
I want to ask you about the response rate because you talked about that. It's not unusual for patients when they start on a BTK inhibitor to feel their lymph nodes shrink in the first week. Like, and it may not be, they're not measuring, they're just noticing it in the shower or when if they have palpable nodes. Do you see that same kind of rapid response in the nodes? Maybe not to the strict criteria of it's calling it a partial response, but you see that same kind of rapid response with this as you do with the BTK inhibitors?
Yes, absolutely. And also what we see, and indeed, yes, we see that within the first 2 weeks often.
Wow.
And also what we see is, as you know, Dr. Kaufman, redistribution lymphocytosis. You know, that little phenomenon which used to scare us when we didn't know any better, when lymphocyte count rapidly rises once you start ibrutinib, right? And these lymphocyte counts, you know, if somebody comes with a white cell count of 100,000, sometimes it can go to 300-400 and can feel very scary. We do see that with BTK degraders as well. And of course, these patients who come to us for a BTK degrader study, they've already seen BTK inhibitor and progressed. They've seen venetoclax, majority of them, and progressed. So they do, many of them do come with high uncontrolled white cell counts. So we do see redistribution lymphocytosis where BTK degraders, by shrinking lymph nodes, push out those cells into the peripheral blood where they promptly die without microenvironment, stromal, lymph node support.
Right. Any final thoughts or message you want to give to patients? And is this trial still open and recruiting? How can patients find out about it?
Yeah, so the trial is open and recruiting. Another BTK degrader that we also have an open trial is NX-2127. Maybe we'll talk about it separately. I think it's a very exciting new class of agents, which I believe in the future will reshape how we treat BTK inhibitor resistant CLL and potentially other lymphomas as well.
Dr. Danilov, thank you so much for the research you and your colleagues are doing at City of Hope. I think it's so important. Thank you.
Thank you.